basically go over some data about epidemiology. I'm going to talk about the virus, clinical manifestations, diagnosis, management, and prevention. So dengue is the most important virus transmitted by mosquitoes worldwide. This is a map showing the global distribution of dengue. And I just want to highlight that there are countries with high seroprevalence, which means more than 60% of dengue. And these are areas such as Southeast Asia, the Americas. There is mid-range seroprevalence areas, which ranges between 10 to 60%. This happens in Africa and the Middle East. And there is some other areas where there is low prevalence, non-endemic areas such as the USA and Europe. So some facts about epidemiology. So dengue is a major public health problem in the tropics and subtropics worldwide. According to the WHO, dengue is now endemic in over 100 countries. And as many as 3.6 billion people reside in dengue endemic areas, which is about 40% of the world's population. Each year, 400 million people are infected with dengue, and 100 million people become ill, and 21,000 people die. And this is a reportable condition in the US since 2010. So the mosquito vector is expanding. This is affected by different reasons. One's climate change. Global warming has had an impact on the expansion of the mosquitoes. Some other factors include population growth, human mobility, lots of travel, lots of moving to other places and countries, urbanization, and there are actually new areas now that are showing dengue, such as Spain, Portugal, and southern USA. So this is a map from the WHO that shows the global geographical distribution of dengue cases from January to April 2024. So a little bit, some recent data. The dark areas showed areas where dengue is endemic. And these are areas such as Southeast Asia, parts of Africa, the West Pacific, countries such as Australia, China, Cambodia, Fiji, and parts of the Americas. This is a map that shows dengue cases in Africa from 10 years, from 2011 to 2021. The red areas recorded areas where there have been outbreaks in the last decade. And these are countries such as Egypt, Sudan, Ethiopia, Kenya, Somalia, Tanzania. The pink areas don't represent any areas where there have been outbreaks, but they have been cases in the last 10 years, locally or acquired by travelers. And tan areas, there are no recorded cases. So this is a map that represents the dengue cases in the USA so far in 2024. And I want to highlight the states that have the higher cases of dengue, and those are California, Florida, New York. So far in 2024, they have had more than 250 cases. And of course, Puerto Rico is one of the states that has, a lot of cases in the US. So a little bit about epidemiology in endemic countries. So the disease occurs year-round with higher incidence during the rainy seasons. There is moderate to high annual incidence is detected with cyclical epidemics that occurs every 3 to 5 years, represent in the graph that I show on the right-hand side. And there are increased cases in high population density and poor housing conditions. So a little bit about the virus. So this is called the dengue virus, and abbreviations DENV, DENV. The infection is caused by 4 related RNA viruses of the genus Flavivirus family, Flaviviridae. There are some other flaviviruses that are listed here, such as tick-borne encephalitis virus, West Nile virus, Japanese encephalitis virus, and others that are related. And their similarities with these other neurotropic viruses are very evident. So dengue viruses are single-stranded RNA viruses, and there are 4 types. These are called serotypes. The serotype 1, 2, 3, and 4. Each serotype has different interactions with the antibodies in human blood, and they share approximately 2/3 of their genomes, with different genotypes existing within each serotype, which can vary in disease severity. So transmission of dengue is through vector-borne, through the mosquitoes. There are two types of mosquitoes. The most important one is Aedes aegypti. The virus is in the saliva of infected mosquito, and humans are the primary host. The source of virus for female mosquitoes is a blood meal from a viremic human. Unless blood is involved, dengue virus is not transmitted by respiratory droplets, saliva, or sexual contact. So this graph represents the mosquito-borne transmission, and there are 3 periods. So the first period is the infectivity period that lasts between 0 to 7 days. In this period, the dengue-infected viremic person gets bitten by a mosquito. This period is followed by extrinsic incubation period, which lasts between 8 to 12 days. In this period, the mosquito ingests the dengue in a blood meal, and dengue virus replicates in the mosquito 8 to 12 days before the mosquito is able to transmit the dengue to a person. Lastly, there is the intrinsic incubation period that lasts between 3 to 14 days. And then this happens, the infected mosquito bites another person and transmits the dengue virus. This virus replicates in the person 3 to 14 days before the symptom onset. After incubation period, then the human becomes ill. So these are the different modes of transmission. So mainly we have the transmission through mosquitoes, but there are some other ones that we need to recognize, such as perinatal transmission, needle stick injury or lab accidents, blood transfusions, and organ transplantation. A few mosquito facts. So the dengue mosquito, or Aedes mosquito, lives in around human habitations, such as houses, schools. It rests in dark areas, such as linen closets, under beds. It bites and takes blood indoor during the day, but also mainly in dawn and dusk. And the mosquito lays eggs preferentially on the insides of artificial water holder containers, such as tree holes, septic tanks, tires, and all of these areas that could accumulate water. So immunity against these viruses is very interesting. So infection with any of the 4 dengue viruses can result in asymptomatic infection to severe, potentially life-threatening disease. Humans can be infected with a dengue virus 4 times over their lifetime because we have 4 serotypes, and they can have more than 1 episode of dengue from these infections. Human infection with 1 serotype is believed to confer long life serotype specific immunity, but only short life cross immunity between serotypes. Which this means is a person infected with dengue serotype type 1 cannot become ill again as a result of dengue serotype type 1. But then there is going to be short-term cross immunity against other dengue serotypes, but only for a short period of time, like 2 to 6 months. So a little bit about pathogenesis of severe dengue. So severe dengue most commonly occurs among patients with secondary dengue infections and infants with primary infections. So the most widely cited hypothesis for the pathogenesis of severe dengue is called antibody-dependent enhancement. ADE is the abbreviation. And this graph just represents this process. So ADE is a process in which the dengue virus complex with non-neutralizing antibodies enter macrophages or monocytes, and then increasing virus production. So there is enhanced viral replication, increased virus production, therefore there is going to be a more intense and complicated illness. So the risk factors for severe dengue, age is one of them. So infants to seropositive mothers are going to have risk factors to get severe dengue, and also elderly people. Then the number of infection is also definitive. So usually people that get second infection will get more severe dengue than people who get first, third, or fourth infections. And of course, people who have comorbidities such as asthma, diabetes, hypertension, sickle cell disease, obesity are going to be at higher risk of getting severe dengue. So before 2009, dengue was classified in three different stages. So it was dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. After 2009, WHO came with this new classification called that has three different phases, which is dengue, dengue with warning signs, and severe dengue. So just going over that. So the first one is dengue, is a person who has a fever and two of the following: nausea, vomiting, rash, aches and pains, a positive tourniquet test, leukopenia. So they need to have fever and two of those that I just listed. The next category is dengue with warning signs. In this category, people will have one or more of the following warning signs. They're going to have abdominal pain, persistent vomiting, which is defined as more than 3 episodes in an hour or more than 4 in 6 hours. Clinical fluid accumulation represent like showing as pleural effusions, ascites, mucosal bleeding, lethargy, liver enlargement, and progressive increase in hematocrit. Lastly, severe dengue shows as one or more of the following. So severe plasma leakage leading to shock, respiratory distress, severe bleeding, and severe organ involvement that can include liver, heart, brain. So this is just a slide that I'm going to show here representing the clinical course of dengue. So after an incubation period, which lasts between 3 to 10 days, the illness often begins abruptly with fever and will follow 3 phases. So the febrile phase is represented here right after the incubation period and can last between 0 to 7 days. This febrile phase is followed by critical phase that usually happens after the patient defervesces. So the fever is gone. People think patient is getting better, but actually some of the cases can go to the critical phase that lasts between 1 to 2 days. This critical phase is followed by recovery phase that lasts between 3 to 5 days. And then just something to highlight is the viremic stage. So if you can see in the green rows below, viremia happens usually during the febrile phase. And after that, the patient is no longer viremic. And this is important for diagnostic purposes that I'm going to mention later. So a little bit more details about the febrile phase. So fever is the most common presenting sign in a person with dengue. Okay, usually it lasts between 2 to 7 days. The onset is abrupt, and patient has any of the following symptoms. So they have severe headache, retroorbital pain, they have significant myalgia, arthralgias, they have a transient maculopapular rash, and they have minor hemorrhagic manifestations such as petechiae, ecchymosis, epistaxis, bleeding from the gums, hematuria, or they have a positive tourniquet test. They can also have facial flushing or erythema, injected oropharynx, and they can also present with anorexia. So a little bit about tourniquet test. This is something that you would inflate the blood pressure cuff to a point midway between systolic and diastolic blood pressure. You wait for 2 minutes, and then you count the amount of petechia that are in 1 square inch. Usually, positive tourniquet test is defined as more than 10 petechia in that area. And you can see that that's a positive test in the picture. And the rash here, it's a macular rash erythematous that is coalescing. And this is the first rash that happens in the illness. There is a second rash that I'm going to mention later. So the febrile phase is characterized by some lab findings. So patient would show leukopenia, mild to moderate thrombocytopenia. They can have elevated liver enzymes such as AST and ALT. They will have hyponatremia, and they can have a normal or slightly increased hematocrit. So after the febrile phase, we have the critical phase, which happens exactly after the patient defervesces. And then these critical phase has some warning signs, such as ascites and pleural fusion that just represent clinical fluid accumulation. Patient would present with hepatomegaly, severe abdominal pain, persistent vomiting, mucosal bleed, lethargy, or restlessness. The lab findings from this critical phase we showed significant thrombocytopenia, there is rise in the hematocrit, and there is going to be leukopenia too. So during this critical phase, then we can have severe dengue that can happen in 5% of clinically apparent cases. And severe dengue has three different presentations, has three different modalities of presentation. So one is severe plasma leakage that can be represented clinically by shock or fluid accumulation with respiratory distress. There is going to be severe organ involvement with hepatic liver enzymes elevated, more than 1,000, neurologic manifestations such as lethargy, impaired consciousness, and myocardial dysfunction. And the third way it can present will be with severe bleeding. Patient would have epistaxis, GI bleeding, hypermenorrhea, and gum bleeding. So after the critical phase, we go to the recovery phase. These last about 3 to 5 days. In this phase, patient starts, getting better. There is gradual reabsorption of extravasated fluid from plasma leakage over, 2 to 3 days. There is going to be increased diuresis, hemodynamic status stabilizes, and patient can temporarily become bradycardic, but would be hemodynamically stable. So something to point out here in the recovery phase, we can have a second rash that is called convalescent rash. It's also called islands of white in a sea of red. And you can see here in the pictures, there is erythema, but you also will see, white areas. These rash can be pruritic and patient will desquamate. And in addition to that, during this recovery phase, patient would have severe fatigue. In the recovery phase, the hematocrit starts stabilizing, white blood cell count starts increasing shortly after the effervescence, and the platelet count also starts increasing. So how often do people get, severe disease? So this is just outcomes in general from dengue. So thankfully, 60 to 80% of people who get dengue will be asymptomatic, and 20 to 40 will be symptomatic. Of those who are symptomatic will get just dengue, between 95 to 99%, and only 1 to 5% will get severe dengue. Of the people that get severe dengue, most of them will survive, but there is a 0.5 to 5% percentage, 5% of people that can die from dengue. So as far as diagnosis, so there are several entities that we have to keep in mind with dengue and differential diagnosis. So different viruses such as measles, rubella, enterovirus, adenovirus, influenza, arbovirus, and West Nile virus infection can, show up like dengue fever. There's some other ones that we can see also. So typhoid fever, leptospirosis, scarlet fever, toxic shock syndrome, meningococcemia. These are bacterial infections that can show up like dengue infection too. And there's some other ones like you guys have more commonly in Africa, malaria, and some other areas with Chagas disease that can present like dengue. So how we diagnose dengue? So it is very important to recognize the different phases of dengue and try to get specimen as soon as you suspect it. So there are specimens that you can collect in the febrile phase, and there are some specimens that you should collect in the convalescent phase. Okay, so remember the febrile phase is the 7 days or less after the fever onset. You should obtain a serum specimen as soon after the onset of fever as possible. That way you have higher yield of diagnosing dengue. So the earlier the specimen is obtained after illness onset, the more likely a lab diagnosis can be made. So the best tests in these febrile phases will include dengue virus-specific polymerase chain reaction, which is PCR. The next one is antigen immunoassay that will show the non-structural protein 1 called NS1 and the IgA immunoassay. So the second second phase that you can collect specimens will be in the convalescent phase. And this is 5 days or more after the fever onset. In this particular phase, then you can collect an IgM immunoassay, and then you can collect an like an IgG immunoassay. This IgG will remain elevated for life after infection, and you would have four-fold or greater increase between acute and convalescent samples as indicative of recent infection. So this is a summary that shows, depending on the phase, which are the best tests that you can collect. So once again, on the febrile phase, we should go and collect PCR test, okay? You also should collect the non-structural protein 1 antigen test, and you can also do IgM test that at that time is just increasing. Then in the critical and recovery phase, then likely your PCR might not be positive, okay? And then at this time, you should rely on IgM and IgG. So a little bit about management. So dengue gets classified in 3 different management groups. There is Group A, Group B, and Group C. Group A includes patients that can be treated as an outpatient, okay? These patients should meet the following criteria. They should have no warning signs. They should be able to receive adequate volume of oral fluid, so they are able to take oral intake and fluids. They have good urine output, and they have a stable hematocrit, and they're hemodynamically stable. These are patients that you can send home with specific, instructions to get better at home. Then there is a Group B when you start treating them inpatient, and they must meet at least one of the following. They start showing warning signs. They have coexisting comorbidities. They can have diabetes. It is an infant. There's a pregnant woman. They have renal failure, or they're elderly. And then they also have challenging circumstances. So they're going to be very difficult for them to come back to the hospital. They live far away. They live by themselves. So in this situation, you should do inpatient management. Lastly, Group C, this is the patients that are going to be the sickest. So they must meet at least one of the following. They have severe plasma leakage with shock or fluid accumulation with respiratory distress or ascites. They have severe bleeding, and they have severe organ involvement. So I'm not going to go in detail about treatment. That's a complete different talk, but I'm going to go through a little bit some tips. So fluid replacement is life-saving in dengue. Okay, this has to be given cautiously, and it should be discontinued when plasma leakage subsides to avoid iatrogenic fluid overload. We should avoid aspirin and NSAIDs to minimize potential for bleeding. And then something very important to know is that secondary prevention measures and early identification and correct clinical management reduce fatality from 10% to 1%. So this is essential. This is very important for us to protect our patient to become sick and die from dengue. So you might say, well, how do I identify plasma leakage? So patients with plasma leakage will have hemoconcentration. So they will have a hematocrit more than 20% higher than the person's baseline, or drop more than 20% of baseline following volume replacement. And also they would have pleural effusions and ascites that can be represented by respiratory distress, chest x-rays that are abnormal showing pleural effusions, abdominal pain, fluid wave and shifting dullness, and this can show by abdominal ultrasound. So a couple of things that we should not do in dengue management. So we shouldn't be using routine corticosteroids routinely. Okay, they're not routinely indicated, and actually steroids can increase GI bleeding, can cause hyperglycemia and immunosuppression. So don't give prophylactic platelet transfusion for a low platelet count. Okay, giving platelets do not decrease the risk of severe bleeding and may instead lead to fluid overload and prolonged hospitalization. We shouldn't give half normal saline, and then we should not assume that IV fluids are always necessary. Okay, so we have to first check that patient can actually tolerate oral fluids, and this will be ideal to be given before we give IV, if they're of course, not extremely ill. Then things that we should do. So we should tell the patient when to return. Okay, teach them about warning signs and their timing and the critical phase that follows the effervescence. Um, we need to recognize the critical phase, as I mentioned before, the symptoms and signs of critical phase. Do closely monitor fluid intake and output, vital signs, and hematocrit levels. We should be able to recognize and treat early shock, and we should administer colloids such as albumin for refractory shock. So some tips about outpatient management that we should tell our patients. So first of all, control the fever. Okay, we should recommend them to get some bed rest. We should prevent dehydration. Okay, so just give them oral challenge and make sure they tolerate, small amounts of fluid slowly every 10 to 15 minutes. We should teach them how to prevent spread of dengue within their house. And we're going to talk a little bit about that in a minute. And we should teach them about how to watch for warning signs. So the CDC has a lot of tools that we can print and give to the family. They have different languages, and I think we can use them, and they have graphic ways to show them how to take care of dengue in the outpatient setting. This is just a screenshot of one of the CDC handouts. So inpatient management, so very frequent monitoring of vital signs and hemodynamic assessments, detailed fluid balance and input and output, and organ function monitoring is important. Serial labs, including liver function tests, renal and acid-base balance, hematocrit monitoring, IV fluids that should be isotonic or colloid for refractory shock, and monitor signs of hemorrhage. So I would like to touch a little bit about vaccines because this is something very important. Of course, these vaccines are not widely available, but I just want to tell you, what have been the most recent updates on vaccines. So I'm going to talk about mainly two vaccines. The first one is called Denvaxia or CYD-TDV. This is a recombinant live attenuated tetravalent vaccine on a yellow fever virus. The schedule of these is 3 vaccines, 3 doses, 6 months apart. So we give it a 0, 6, and 12 months. So, the schedule is not user-friendly, but this is how it is. It's 3 doses. The WHO recommends it for seropositive people that are between 9 to 45 years of age, and all people, regardless of seropositive status, if they live in a high seroprevalent area. The CDC recommends in patients 9 to 16 years of age in living endemic areas in the USA, but this is not recommended in travelers. For this particular vaccine, patients need to have a pre-vaccination antibody screening. They should be positive for that before we give the vaccine. This vaccine is contraindicated in people with severe immunodeficiencies or immunosuppression, and efficacy ranges between 65 to 84% among seropositive people. Next vaccine is called Qdenga or TAK-003. This is attenuated dengue virus serotype 2 and 3 chimeric viruses for each of the 4 dengue serotypes. This vaccine has 2 dose schedule at 0 and 3 months. They're 3 months apart. The WHO recommends that to be considered in children 6 to 16 years living with high transmission intensity. This is licensed in Indonesia, Brazil, UK, Germany, Argentina. This is not approved in the US. Pre-vaccination antibody is not recommended for this vaccine, different than the previous one that I just discussed, and efficacy is a little bit lower, 64%. This is among seropositive people. So a little bit about prevention. So it's very important prevention of dengue, and this is what when we have travel clinic, we talk a lot about prevention, how to prevent infections such as dengue or chikungunya or other things. So mostly we have to tell them about how to prevent mosquito bites and how to prevent, the breeding of mosquitoes. So we have to tell them about clean inside of water containers to remove mosquito eggs, such as PET water bowls, flour, planter dishes. Cover all water storage barrels to avoid mosquitoes breeding there. Empty and clean containers with standing water indoors and outdoors, such as vases, discarded tires, trash containers, buckets, planters, toys, pools, and bird baths. Then protect against mosquito bites, especially when you have a household member that is sick. So bed nets are very important to have. Use repellent on the skin while indoors or out and reapply several times a day. And then wear long sleeve clothes and make sure window and door screens are secure. Okay, with these, I am going to finish my presentation. I'll be happy to take any questions.
Great. Thank you so much, Rodriguez. That was a fantastic presentation, and I certainly learned a lot, as I'm sure our guests have as well. We will now open up the floor for questions and answers, and I'm happy to get started. I heard you mention the role of steroids in treatment of dengue and how it seems like it's not empirically recommended. Is there any evidence of use of IL-1 or IVIG in the management of severe dengue? Any role for those?
I didn't find anything about that in my lead search. Okay, I think it's mainly the management for dengue is supportive management and preventive management. You have that patient that has just the dengue part, you're not in the critical phase yet. I think it's mainly prevention. Okay, like appropriate management of intake and output, hydration, supportive care. But no, I didn't find anything about IVIG or interleukin treatments.
Gotcha. Um, and another question, do we have any data to support the development of antivirals to assist with kind of viral clearance of dengue?
Not so far. What we have right now is, the vaccine development. Okay, but unfortunately, this is not recommended, everywhere. As I mentioned, one of the main vaccines that is actually approved here and in other places of the world recommends 3 doses. Okay, and they're like 6 months apart. So this is not something that is going to be widely used. It's only recommended for people that live in endemic countries, and I think that's going to be the main way just to prevent dengue, but not as far as antivirals. I couldn't find anything. Another thing is that even with people who are going to travel to endemic areas, the vaccine is not recommended. Okay, this is just for people that live in endemic areas.
Understood. Thank you.
You're welcome.
We have a couple of questions from the crowd. One question is how to manage the urticaria that can be associated with dengue. Any recommendations in that regard?
So, you mean like the in the recovery phase when we can get the second rush that is extremely pruritic? I think is mainly supportive care. I think it's just antihistamines, hydration, even topical medication. But for example, it's not recommended to give systemic corticosteroids for that. It's going to be mainly antihistamines and topical treatment.
And another attendee asks about the mechanism of bleeding in dengue fever and how to, manage and consider thromboprophylaxis, such as low molecular weight heparin. in these cases?
So I think mainly the management for bleeding in dengue fever is going to be, I mean, hopefully preventive, right? But things like blood transfusions or like platelet transfusion is not recommended. Okay. I mean, in some instances when the bleeding is so bad, I mean, you should be able to give factor red blood cells. But for example, platelets, because that's the main, you have thrombocytopenia, that's the main way you can have bleeding, is not recommended to give platelets. It's mainly, fluid replacement um, before you proceed with like giving blood products. But the
Okay.
main mechanism of bleeding in dengue is caused by thrombocytopenia.
Seems like we have another question. The attendee is asking about how to approach dengue expanded syndrome.
Dengue expanded syndrome. I haven't heard of that. Could you elaborate more?
Maybe we can have our attendee maybe rephrase the question.
Dengue expanded syndrome.
Hmm.
I haven't read about that, but I will, and I can send an answer to the email, but I didn't read about dengue expanded syndrome. Sorry about that. I haven't read about that one.
No worries at all. Just making sure that I haven't missed any other questions. Okay, great. I think that we have gotten everyone. Thank you so much again, Dr. Rodriguez. This was a fantastic presentation. I think people are even asking for your slides. This presentation and slides will be uploaded on our YouTube channel and can be viewed at any time there. And this presentation will also be on our education website as well. Thank you so much again, Dr. Rodriguez. This was fantastic. I think we will conclude.
Okay. And Dr. Robin Maskey, I'm going to look up the dengue expanded syndrome. If you can send me an email, I'll be happy to send you an answer on that.
Excellent. Thank you all for coming, everyone.